wait for 5 seconds and then. Yeah, we are live, Ronan.
Right. Good evening, everyone, and welcome to the 33rd IAA Indian Arthroplasty Association's 360-degree webinar. And we've got a very interesting topic this evening, the role of 3D printing in arthroplasty. I mean, this is one of the newer emerging technologies that's been around for a while. And we've got a large number of speakers who are going to share their experiences in this particularly innovative field and show us and tell us how it can be applied to our day-to-day practice. And to conduct this webinar this evening, I've got our convener for the IAA, Dr. Rajiv Sharma, who will be taking over from me for now. So I hand you over to Rajiv and wish you all a very pleasant evening.
Thank you, Ronan. The convener for this webinar is Dr. Ajit. Thank you, Ajit, for fixing up such an interesting program. There are 5 talks in this webinar, and then after the case discussions, we have very good faculty in this webinar. Dr. Vaibhav Bagaria from Mumbai, Dr. Ravi Bashal from US, who will be joining us in a few minutes, Ashish Furnace from Mumbai, Dr. Srinivas Kasha from Hyderabad, Dr. Vikas Jain from Vapi, and then case discussions will be conducted by Krishna, Dr. Krishna Kiran from Hyderabad, Dr. Kalaivanan from Chennai, and Professor Sean Von Young, who will be showing the case, and Dr. Shobit will be translating for him and supporting him, and Dr. Lalit Mani from Delhi will be presenting his cases and discussing it further. So Ajit, maybe we just invite Dr. Vaibhav to give us the overview of 3D printing. Unmute yourself, Ajit.
Yeah, extremely grateful indeed to Dr. Vaibhav for taking the lead in organizing the faculty and getting ahead. I thought this is a very interesting technology. I've had the opportunity to work with this system of technique by being used by our oncosurgeon really, and I thought it would be very, very apt for us also, because we use such we do such complex cases both in the hip and knees. So I thought this would be a very good session. So thanks, Dr. Vaibhav. The field is open to you now. Thank you.
Thank you, Dr. Ajit. I'll start with sharing my screen. Is the screen visible?
Yeah. Yes, Vaibhav, please go ahead. Please go ahead, Vaibhav. We can see your screen.
Is the signal weak?
Professor Ajit, is the screen visible? Yeah.
Yeah.
Go ahead.
Please go ahead. I think your signal is a little weak.
Yeah. Am I audible as well?
Yes, please.
Okay. So I begin by saying that if a picture is worth 1,000 words, and this is one of the slides that I saw from one of the advertisement that government of India had given.
Rajiv, it might be worthwhile moving on to the next speaker.
Yes, that's right. Vaibhav, maybe in the meantime, when Vaibhav is able to set up his computer in a proper way, we can request Dr. Ashish Furnace to speak. Ashish,
Hi, sir.
are you
Yes,
available?
sir.
Hi.
I'm here.
So can you share your screen?
Yes.
And we'll invite you to speak on use of 3D printed model for complex primary hips.
Is my screen visible, sir? And
Yes, please. It is visible.
Yeah.
You're audible.
Yeah. Thank you very much, sir. And thank you very much, Indian Arthroplasty Academy and Association for having this interesting webinar. And so my premise is to talk about 3D printing models for assisting us in performing a hip replacement. And as I was going through the program, it is a very star-studded faculty with people who have got a vast experience in using 3D printing for executing joint replacement. I think most of my talk is going to be done by our colleague, Dr. Vikas Jain, but I would just sort of, warm up the audience to this 3D printing. Right. So the essential ingredients of a successful total hip arthroplasty, as we know, is planning. And the goal is to restore the functional anatomy, to restore the hip center, which is determined by the acetabular placement, to restore the offset, leg lengths, the abductor lever arm, and to ensure a stable hip joint, which permits an early weight bearing. Now, if you see the normal anatomy of a individual or individuals, it falls within a particular sort of range. There are, however, a few outliers for which we have a plethora of implants which are standardized and which are very well available. They allow us to perform the hip replacements in the vast majority of the patients without resorting to use some special implants. Now, we have come a long way from the time when we're using acetate templates to template our total hip replacements to see what is the optimum position of the components that we will be aiming for or using them to perform. So moving on from that, there are certain parameters which are known to us that we need to template the acetabulum first. We need to determine the center of rotation, find where the teardrop is, the wall, the coverage, and an optimum position of abduction so that the patient can get a good function. Similarly, there are parameters for the stem, and certain parts of the stem which are lying outside are responsible for the biomechanics. Now, all these parameters, as I mentioned, are good enough for people who have got a decent anatomy. The advent of electronic picture archiving communications in PACS and electronic X-rays has led to us using certain softwares which are freely available on the internet to do our day-to-day sort of planning, executing, to see what sizes of the implants, what is the size of the acetabulum or the stems that we would be needing. However, the dysplastic hips or the outliers from the previously mentioned, the population or whose parameters fall outside this purview, who are having previous osteotomies, a trauma, or basically a distorted anatomy, like this gentleman, pose a challenge to us. Now, this gentleman is a gynecologist. He's a practicing gynecologist, and he had multiple surgeries on his hips as a child, the details of which we don't know, but we can assume that, he would have had some osteotomies, and he has a dysplastic hip, and on a plain X-ray, it becomes very difficult for the occasional hip arthroplasty surgeon, like someone who does not have a very high volume or who sort of does routine sort of hip replacements regularly and occasionally comes across the dysplastic or really distorted hip. It becomes a difficult or a challenging situation to judge what his anatomy would be. So this is where 3D printing comes in handy. So here we had got the patient's 3D CT scan done. We had got it printed because these 3D printers are now affordable. The process is quite simplified. It is available in almost all the cities and people across the country can access these at a very short notice and at a reasonable price. And there has been a lot of interest in its applications. So going forward, we got his 3D models printed. And as we can see, as we had suspected, that his canals would be very narrow. So these are life-size printed models of this particular hip. And you can appreciate that there is a shallow acetabulum, there's a false acetabulum. The femoral canal is quite narrow. And using the advantage of these sort of models, we could see whether we could get the smallest size components or smallest size prostheses in. These models enable us to sort of perform a mock surgery before the actual surgery and see what the position of the reamers and the position of the components we could achieve. Once we have done that, we can even see if there is a the extent of coverage of the acetabulum that you're going to get, the quality of the bone that is going to be around, the thickness of the walls if you have reamed up to a particular sort of level. So having done that, we can proceed with a reasonable amount of confidence that yes, you can get a decent sized cup in. It will be a good cup. We can get a good coverage. And this, our planning is done to the next level. It's just not planning on the acetate templates and on the X-ray, leaving a lot to guesswork. But here you can be very confident that yes, I will be able to get a decent coverage. And this is where I would be. These models are sort of sterilizable, but you can keep it in the operation theater handy so that you can constantly keep on referring to it. In case you get lost, we can always come back to the anatomical landmarks which are there on the model. At the same time, compare that with the anatomical sort of landmarks on the patient itself. These are sort of in the office, placing the components and seeing what the position is. And of course, because it's a 3D printed model from the same patient, the anatomy usually mimics or reflects what you have seen in these models. Or having performed the sort of, the exposure, the dislocation, the reaming, and sort of ultimately you could sit the components and we could get the sort of the standard, this is a cemented C-stem coral sort of cup with a cemented stem to negotiate the narrow canal. So all in all, what I'm trying to highlight here is that there was a possibility that we would require dysplasia stems or a special stems or special sort of equipment for this. But here, because of the pre-op planning, we could be a little bit more confident when we were sort of, approaching this particular patient who sort of is a difficult or poses a difficult challenge. Now, coming to the next, this thing, though this is not a primary total hip arthroplasty, this is a peculiar situation where this is on the right hand side, this is a very old bipolar hemiarthroplasty which has been inserted quite a few years back, and we can appreciate that there is a lot of thinning of the acetabular wall. There is a lot of lysis and there is a lot of wear. So this patient comes very late, and it becomes very difficult even after we do a CT scan to appreciate the thickness of the walls that is there. Because of the scatter that the metal would sort of throw. So again, here a 3D printed model will be very handy. So we got a 3D printed model. Once we had a 3D printed model, you can appreciate how thin the walls are and how oblong shaped the defects would be. So knowing these defects preoperatively or before you begin the surgery, you can plan whether you would require some kind of a cage or any kind of augments. So you can be prepared with the necessary inventory and sort of, when you head in with the surgery, your already job is half done, that you know that this is the end point that I am going to achieve. This is the path that I'm going to follow. And this is where I'm going to be after, after the initial reamers or whatever reamers I have planned. This case that I have borrowed from one of our colleagues, and he's an ortho-oncology surgeon, Dr. Michel Parikh. So you can see on the left-hand side, the acetabulum is a little destroyed and there was a sarcoma, though this is not strictly a primary hip replacement. This is done for malignancy, and you can appreciate that there is a huge tumor. So what Dr. Michel did was he used the MRI to create a model of the pelvis, MRI and the CT. The 3D model with these CAD/CAM designs also permits you to sort of, do a preoperative planning. Now, this part of the talk, I'm slightly impinging on Dr. Vikas Jain's talk, that here the 3D printing sort of, the mechanism, the engineers can give us a jig where if we tell them that this is the cuts, that this is the part of the pelvis that I need to take out, they can prepare a sort of a jig which will give you these, slots for the saw to take this bone out. Using this CAD/CAM design, we can plan where we want the hip center, mimicking the opposite side, and 3D print an actual implant, which can just be sort of, fixed on to the patient's hemipelvis. So this is the 3D printed implant which was there. That's the tumor which was excised. And once the tumor was excised, then it could accommodate a standard total hip replacement with a acetabular shell, which was sort of screwed on to the rest of the hemipelvis, which was there. So these were in brief some of the examples where hip surgeries could be performed with a reasonable amount of confidence using these 3D printing applications. Now, having had these advantages, literature is full of areas where we can expand these applications in different areas. We can have 3D printed plates, we can have 3D printed models. Now, when we are discussing about models, it becomes very easy. As Dr. Weber was just saying, a picture speaks 1,000 words, but if you have a model, understanding that particular anatomy, understanding that particular problem becomes extremely easier. So it is very easy to understand. It has got tremendous educational applications. You can explain what you want to someone else very well. These files can be shared, it can be saved, it can be stored. And the best part is, if you have it stored, you can even reprint it for further reference or for your colleagues' sort of education. So you can prepare a collection of rare cases. Now, what we had done in the past, just to highlight while we are on the subject of the pelvis, it will just take a minute or so. So this was during the pandemic, when we used to conduct a lot of courses in sort of physical presence, but the pandemic forced us to think out of the box, and this is where 3D printing came in handy. So this is a model of a few patients' pelvis, where we have sort of tried to recreate the fractures and the fracture lines on a particular model which we had printed. This model was given to the delegates. This model was given to the faculty, and they were all sitting in different parts of the country, where the faculty was demonstrating the trajectory of a particular screw, the contouring of the plates, the direction of the screw that they needed to put, and the delegates were sitting at their own place and in their own setups wherever they were across the country, and they could sort of understand exactly what the faculty was wanting to show. These models were sort of these can be made from different materials, whatever you would choose. So in this case, it was some I don't know the technical name, but it was a sort of a very reasonably easily available plastic material which was used. It was a bit radiolucent, so the delegates could get the X-rays, or in case someone wants, I mean, we had this model. So then later on, in case of these fractures, we could just practice the passing the screws, contouring the plates before the surgery. So it becomes very handy. So to extrapolate this could later on also be used to sort of, as I mentioned, to contour the plates, to use the particular, do the steps of the surgery. So it becomes a good pre-op planning tool. It becomes very easy for a doctor-patient communication. We could explain to the patient why these augments are required, why the surgery is a bit complex, and what are the challenges we are going to face. We can explain the patient very easily. It becomes very easy for a doctor-doctor communication. Let's say we want to explain this thing to our assistants, to our seniors, or our juniors. It becomes very easy and reproducible. The blueprint for the future could be that, if you have a collection of these models of different parts or different dysplastic hips, they could be used for performing lab-based studies, evaluating some stress-strain relationship or different. So the possibilities are endless where we could do all these things. So 3D printing has a future sort of potential to revolutionize orthopedic training, I would say, more than that and more than the surgery. The use in everyday clinical practice is going to increase, and it will only depend whether we are able to outflank the disadvantages, which we rely on, the likes of Dr. Vikas Jain, Dr. Vaibhav Bagadia, and the IAA, sort of to step in and to drive home the message that the robotic is here to stay. But this is a possibility. This is very handy. I mean, it is cost effective. It increases your confidence, and yes, you can do a sort of a dress rehearsal before you actually go in for these complex surgeries. The costs are getting lower and lower every day. The printing speed and the turnover time is also decreasing, and is becoming very handy for the surgeons to sort of get these technologies in their consulting and their operating theaters, and these are very safe. So basically, we will still need certain sort of regulatory sort of guidelines in the future if we are to expand its use, and if we are to expand its usage into creating jigs or printing components, as we will hear in the future in the further talks to come. So all in all, these particular complex patients which I showed in my hand, they had only one chance at a surgery. I couldn't afford a failure, neither can any one of us afford a failure. So if anything can be done to make the surgery very predictable, I think this was it. And these were just the two examples that I wanted to highlight. Thank you very much.
Thank you, Ashish. Thank you so much. I think you made this difficult looking topic very simple, and we'll just take it on with the next discussions. Do you have more slides, Ashish?
No, sir. I'm done, sir.
Yeah. Thank you so much. I think we'll take up the questions at the end of this 5 talks. Vikas, next will be your talk on 3D printed cups.
Yes. Very good evening to all. Let me share my screen. Ashish, by the way, you have not overlapped any part of my talk because I'm specifically talking on the acetabular cups. And in fact, you made my explanation to the entrance to this 3D technology much easier. Thank you so much for that, Ashish.
Thank you.
Okay, where?
PowerPoint.
And Vikas, we'll request you to limit to the time.
Yes, sir. Yes, sir.
Thank you so much. Thanks so much.
Can everyone hear me? Can you see the
Yes,
slide?
yes. Yes.
So friends, to introduce myself, I am not an arthroplasty surgeon, but I am a keen follower of 3D technology since last 3 years. And getting this technology to orthopedics, as I could see, there were so many challenges in different aspects of orthopedics, where arthroplasty being one of them, where we could come out with the solutions that the arthroplasty surgeons were finding them as challenges. We went ahead and now we have come up to the product end. So presently, what Ashish was talking was about education that we could use the 3D technology for, right from the use of the patient's DICOM model, and then from the DICOM to segmentation. So it's not very technical. It's the CT scan. It's the information that you get from the patient's CT scan. That information is then taken onto a software which is available, and on that software you start to play with that information in order to get the solution that is required by you. I'll not go into the details of that because I'll limit myself to the acetabular side and how 3D technology has enabled us to come up with a product. Now, this product is not new. This is nothing but it's a trabecular acetabular cup, which you can see. And if you can see that there are trabeculae projections that are seen or irregularities on the cup. And why did this thing come? And what is the importance of it is what we will shortly discuss in this presentation. So the key things that you would see probably, Ashish has shown one or two examples, and subsequently we would be seeing a lot of examples because this technology it helps us predominantly focusing on the bone defects. As you can see, there are different shapes, sizes, and the surface irregularities that you would find patient to patient. And then using this off-the-shelf modular acetabular cups or implants do cause a lot of challenges in our day-to-day arthroplasty, whether it is primary or whether it is a revision arthroplasty. We'll shortly try to cover and understand what is osteointegration, because here we'll be talking a little bit on what is bone, metal, bone cement, and a metal cement interface, and what are the integration, what were the challenges in that integration. We see a future, we are progressing towards uncemented arthroplasties. Think in terms of customization. So till now we use off-the-shelf modular prosthetic implants. Now we are entering into an era of customized prosthetic implants. Friends, optimization is what we as an musculoskeletal surgeon should aim at. We should always aim at giving a precise and a perfect anatomical reconstruction. A lot of been said about the bone defects. I'll not go into the details, but I'll tell you why this additive layering or an additive manufacturing has come as a help or as a solution to this particular problem or a challenge that every arthroplasty surgeon, even a primary complex pelvic trauma surgeon faces. By using this technology, we would be in a position to now give you a product which will exactly fit into the defect that is created by the bone. So the time has now gone in terms of even using augments. You would not require to use augments. You will get an acetabular cup which has an inbuilt augment, as well as you would find that whatever is the defect on the ilial side, all these defects would be printed on a metal printer, which I'll show you subsequently, and that exactly will be fitting onto the defect that you will see when you open up your patient. And the orientation, the anteversion, everything would be precise and perfect. These are few things that you are regularly seeing. You would see this. We are using cages What you see here are the acetabular cups. What you see are also few augments, and these augments are used in order to face and correct those challenges which we as an arthroplasty surgeons would be facing in day-to-day practice. However, we have gone a step ahead. As Ashish had given one of the examples in cases of tumor, what you can see on the right side is nothing but it is a pre-planned and now a printed product, which is an acetabular component, which would fit onto the ilium in order to give the perfect and a precise orientation, anteversion, and the patient would get the perfect limb length. Now, this is what we are aiming at to use this technology for. Second is what we are talking in terms of is osteo-integration. This is some place where, our understanding is where we think that we would be able to achieve a biological fixation when we fix an uncemented acetabular component or a femoral component. We rely onto the fact as a part of evolution on a hydroxyapatite coated stems, or we went on to the porous coated. Well, friends, that time has come when now we don't even need an HA coated or a porous coated implant. You would have a 3D printed trabeculae or a lattice implant, which would be abutting the trabeculae of the bone, and that will enable a bone growth within the trabecular pattern in such a manner that the bone and the metal integration is going to be very strong and within a very short period of time. That is the solution that we would be able to get, because such 3D printed acetabular components or a femoral stem is only possible by additive layering technique and not by the machining technique, if you go by the technical way in which the prosthetic implants are made. In your day-to-day arthroplasty, from the integration point of view, we have challenges, as I've rightly mentioned before, about the interface, about the integration and aseptic loosening. Apart from infection, the biggest challenge is over the years, we see that the biological fixation or the bone metal fixation that we aim to achieve after some months or years doesn't happen, and there is a movement that happens in an osteoporotic, say, proximal femoral stem that results into periprosthetic fractures or loosening of the implant is seen. And we really are looking for solutions that we do not end up into having aseptic loosening. This shows how micro cracks even develop at the level of the cement, or how these micro cracks even develop at the level of the bone, at the level of interface. And this micro cracks then result into the aseptic loosening that happens at the level of interface. And we really want the biological bone metal integration to happen, and we do not want any aseptic loosening to happen at that level. So this is a little technical, but this is where how 3D technology is going to enable us to achieve a better metal is to bone integration. That is the second most, apart from the bone defect, that is the second most biggest advantage as far as the product is concerned, which we could make out of 3D metal printing. The process we all know about how it happens, how does the bone to metal integration happens, is following 3 steps. One is osteoinduction, followed by osteoconduction, and then it is followed by osteointegration. The factors which determine the bone metal integration is the quality and the design of the surface of the metal implant. So when I'm talking in terms of acetabular component, why is it that we have come out with different types of trabecular acetabular cups? Few companies have now come up with these uncemented trabecular acetabular cups. Most of them are off the shelf. They are not basically patient specific, while we are looking at the solutions which are from the patient specific point of view. Second factor that determines is the biomechanical bone properties, the quality of the bone, and definitely it is the surgeon and the surgical skill and the way the post-operative care happens. We are more concerned about aseptic loosening. We are concerned about the integration, and we do not want any form of aseptic loosening in a longer period in any arthroplasty. Ultimately, we aim as an orthopedic surgeon that once we put an implant or prosthetic implant, whether it's a femoral stem or a tibia or it is an acetabular, it should integrate so well with the bone that there is no loosening that happens at the interface. And that integration is what is ultimately the long-term aim. This is possible by a printed acetabular, either it's a femoral stem or an acetabular cup. So what it concludes is that creating a trabeculae or a lattice, it augments osteointegration. And using these studies which have happened at the level of metallurgical sciences and at the level of certain orthopedic surgeons across the globe, the entire innovation across last 10 years have happened in the field of 3D technology, where huge companies, the best known, well-known companies in field of orthopedics have already come out with 3D printed acetabular cups and femoral stem. They are using something like this. These are freshly printed acetabular cups from our printer, which we started to print within last 6 days. As you can see, there are multiple types of mashes you see, which we call as trabeculae. You can see micro trabeculae. You can see different designs of trabeculae. Different companies would come out with different designs. However, the aim remains the same. You want this uncemented acetabular cup to integrate with that of the bone. This is where we are going to do it. What you see on the left-hand side is a beautiful 3D printer, which is going to print acetabular cups, femoral stem, and other patient-specific orthopedic implants. These are few CNC machines. To give you an introduction, CNC is a way in which presently the implants are made across the world, where there is a subtraction that happens from a CAD design, where either it's a rod or a plate which is cut in order to make an implant, while additive layering is nothing but there's a metal powder which enables you to layer by layer lay down a particular shape of an implant. And that is exactly the reason we are in a position to now make any implant which is going to enable us to fill that particular defect. So talking in terms of reverse shoulder arthroplasty, you can make a glenoid with a glenoid plate, and that can also have a defect which is there with a perfect antiversion. In case of a revision TKR, you can make a tibial plate along with an augments inbuilt into the tibial plate that will perfectly fit into the bone defect that is going to be there. So that's the level of 3D printing, metal 3D printing, which is going to make the life easier for you as an arthroplasty surgeons across the world. That is what I can say, and we can all rejoice on that aspect, that challenges can be traced. This is something Dr. Mani might cover at the later stage, but this is, and Dr. Ashish was also focusing, is using this information in 3D technology for purpose of exactly performing a surgery, which would be easier even than using robotic surgery. So you can use HoloLenses, you can use that information which will guide you to put your acetabular cup in a perfect antiversion, the perfect center, the perfect rotation. So there are studies which are going where using this technology will make it cheaper, easier and faster, where you can use augmented reality and virtual reality together to do your intraoperative fixations, intraoperative surgeries using HoloLenses. These are not important slides, but just to tell you that there are studies at the metal level which is happening, where say that titanium is one of the best metals which enables us to have a good osteointegration. And next thing that is coming up is at the level of femoral stem, where you will see a lot of studies are happening, where you will find that the femoral stem will be fenestrated. It will be having a lot of holes, which is known as lattice. It will be lighter in weight, and however, it will be biomechanically as strong as it is in the current picture. Thank you so much. This was a little technical talk on the acetabular side in order for you to understand what is the product that we can have from the 3D technology. Thank you so much.
Thank you, Vikas. I think this was a very detailed explanation of a very difficult subject, and we could have a reasonable idea, and we'll be carrying out the discussion at the end of all the talks. The next talk, Dr. Vaibhav Bagaria from Mumbai. Vaibhav, would you like to share your screen? And Vaibhav is having some problem of the connection. So in between, if it is a problem, then we'll take up the next talk.
I think that's been sorted out.
Yeah. Though he's from a city which never sleeps, but it seems to be today an exceptional day.
Full screen? Yeah.
Yeah.
We can see it.
Unlucky day. We have a power outage, so I'm running on mobile hotspot. So I really apologize for that dropout. Yeah, okay. So is worth 1,000 words. Then imagine the power. To give you a brief overview of how 3D printing is done, I call it as a jalebi maker. So you are seeing that this is how a jalebi is made. This is exactly how a 3D printer works. Only that instead of the jalebi maker, the person driving it is a software. So it's a layered manufacturing where one layer over the top is laid on to create a model. And how do we do it? It's just the same that the CT scan images are stacked on the top of each other, and a nozzle creates a layer just like this model here, where we are printing an acetabulum here. These tiny nodules are spewing out nozzles at a very high temperature, and it sticks on each other. So you can see the ileum, you can see the acetabulum, and the down portion you can see as support systems. Now there are different types, but there are
I think the problem is recurred.
Vaibhav, can you hear us?
Printer. One is laser based, the nozzle based. Just to the technology available. Yes, I can hear you. I can hear you. Can you hear us? Can you hear me?
Your connection is unstable.
Am I audible?
No,
You are audible, but
I'm
Vaibhav, it is
mobile.
very broken voice.
Okay, so maybe it might be a good idea for you to play that.
Now it is good. It is good. Please go on.
Okay, so when we look at the overall 3D biosphere, there are 4.
Vaibhav, we are sorry. Probably it is not functioning properly. So, Vaibhav, can you hear us?
One is
Since it
the
is
3D graphy, and is the 3 tools.
I think, Dr. Rajiv, it's better that you play it from your end.
Yeah. Vaibhav, could you unshare your screen, please? Sorry, Vaibhav, this is because of the connection problem at your end. So we'll rather you just try to work it up if it is possible. And in the meantime, we will play the Dr. Ravi Bashyal's talk. Can we see?
Not yet. That's not opening either, Dr. Rajiv. Shall we go on to Dr. Kasha's talk while we are sorting this out?
Are you able to see the screen?
No.
Able to see the screen, but it's still the video is not opening up.
Oh,
Dr.
but on
Rajiv, now
my screen it is working. You're back, then I better stop sharing it. Yeah.
yeah, so I can start now. My electricity is back now. So full
Yeah,
on.
please go ahead. Please go ahead. Yeah.
Sorry about this, guys. Okay.
Go ahead.
Okay, guys. Once again, really apologize, and we'll cut short. So as I said, I think this up to this we were clear. So this is how a 3D printer works here. Okay. And then there are different types of 3D printing system available. The four main types that we need to remember are FDM, SLA, SLS, and PolyJet. They all work in different things. As I said, FDM is the commonest and cheapest one. It extrudes these metal thin plastics which stick on each other to form a layer. And with all the combination of different technologies and the material available today, it is virtually possible to print anything in the world, from houses to chocolates to food material to anything that we see. When we come to orthopedics, we can classify 3D printing into four major categories. First is 3D graphy, which basically means creating models. The 3D tools, which is basically creating jigs. 3D implant that we just heard is creating customized implant. And finally, the bioprinting, which is the final frontier. So this is the simplest example of the models being printed. With case example, this is where we use it. So this is a case of JRA, where we use this, and you can see that this is the actual size of pelvis. It is my hand which is holding it. And we can see that different columns can be studied of how they are, and a judgment made on how your cups can sit. So in this particular case, this was a 22-year-old gentleman weighing only 18 kilos. And you'll see that I have done an actual reaming here to see. And this is the smallest reamer, and I'm using the posterior column to kind of get a good fit. So the smallest 38 reamer is what looks so big on this actual pelvis. And of course, once that's done, you can put a trial implant, again, the smallest available in the world for this boy who had not walked for last 15 years. We did cemented here, uncemented with cage on the other side. Again, coming to the second element, 3D printed jigs, also known as patient-specific instrumentation. Different companies have come up with different categories. You do a pre-op planning on a long-standing thing. This is how CAD-CAM segmentation is done. This is how a jig is created, and we have more of it in talk by Dr. Ravi Bashal. This is how a jig fits in, which are specific to patient's anatomy. The third is what we just heard is about 3D printed implant, which is done by an SLM or selective laser mentoring. And this is usually used for triflange with enhanced coverage. And we heard a lot about how we do not need a porous or HA coated, but a trabecular cups that are there. Again, this is different process in which it is done. A case example here, where you will see that we have got not much host bone. Traditionally, we would use these things. We can use a jumbo cup, you can use a Gans ring. But here what we did was using this particular technology that we were talking. You can take a 3D printing a model. You can see where the bones are. So the red means the dense bone, green means the lesser dense bone. You are mapping it out here. So you can see first step is to study how the bones are. The second step is, of course, to put the implant virtually on this. You can see that we are seeing it. We are trying to put the cup in where it fits the best. I'm putting a debut cup because I can use the same liner as debut. So I'm just seeing where the bones will be, where the host integration will be most, which are the uncovered areas, how will my implant look like. And then once that's done, you can come with this whole iteration. Again, the surgeon sees where it is, which are the areas where you can actually put it, which are non-accessible areas. And then you can come up with a final implant prototype. Again, as I said, this was this particular case, we used this, we did all things. This is a prototype that was done, and you can see how you can press fit it by doing it, and then you can order a final implant. Again, tumor cases where we use it often, and because paucity of time and I've wasted a lot of time, so we'll just come. If people have to read more, they can use this. Some of our papers that have been published in this section. So there are some details about it, how to do it, where to do it, and what are the limitations. This is where we started in year 2008, one of the ugliest model that you can say. But today, when we talk about these 3D printed implants, we are very happy to see they are much more modern. But this model, we keep it very close to our heart, although it is a 15-year-old model, but a lot of lessons to be learned. So I thank you for your attention and would welcome any question and invite you to this another conference where you'll talk a lot about 3D printing called as TTGR. So thank you very much. I hope I could save some time, Dr. Rajiv. Thank you.
Yes, thank you, Vaibhav. It's a wonderful discussion. And I'll once again try to play Dr. Bashal's talk, which I put on a PowerPoint. And I hope
not,
that
then I can
will
do
work.
that.
Yeah, let us see if it works. Can you guys see and hear?
Yes, we can see it. We can't hear it.
Oh, all right. So I can hear it, and I do not know how to.
Would you want me to try and hear it?
Yeah. Can you keep on explaining the talk?
No, I can play the
Vaibhav?
whole talk again if you want me to.
Yeah,
share.
then that'll be the right way. Please do it. We apologize for this confusion because
Is it audible now?
Good morning, good evening, or good afternoon, depending
yes,
on.
it is audible. Yeah.
Volume of it.
My name is Ravi Michel. I'm an orthopedic surgeon here in Chicago in the United States, and I'm really thankful to be on this webinar. I want to thank Dr. Roy, Dr. Sharma, Dr. Kumar, Dr. Raj Kumar, and friend Dr. Bagaria for inviting me to speak. I look forward to talking to all of you about patient-specific instrumentation. I'm recording this presentation ahead of time, given some conflicts with the timing of the actual webinar, but I hope to be able to join you later for questions if the timing works out. So I'd like to move through this and again, have time for questions at the end. And, you know, many of you may have questions about patient-specific instrumentation, why we use it, and what the advantages are. These are some of my disclosures. I'd like to start with cases, to help us put this in context. Here's a severe varus knee, nothing out of the ordinary that you wouldn't expect on a knee that looked like this. And here's a knee with a significant amount of valgus. Again, nothing out of the ordinary that we might expect to see on her exam. So, how might we approach these patients? And a lot of the basics that we're going to review, many of you already know, but I hope to use that as a background and a platform to start to cover some new ground. And while these cases cover complex total knees or a little bit more complex total knees, please keep in mind that many of these concepts apply to primary total knees. And frankly, I use patient-specific instrumentation on a vast majority of the knees that I do. As I mentioned earlier, I have a practice here in Chicago where I just do hip and knee replacements. I do about 600 hips and knees every year, about half and half. So have several thousand knees done. And as I'll discuss later, many of them were done with standard instrumentation, but I probably have, at this point now, approaching 2,500 total knees that are done, that have been done with patient-specific instrumentation. The goals of a knee arthroplasty, as we all know, is to restore alignment, but really is to restore the forces across the joint line. So I'll go back a slide here, but the guiding principle here is that we want to balance forces across the knee. And as many of us have become attuned to with emerging technology and emerging thought, there are thoughts behind sometimes using bony cuts to help us with limiting our soft tissue releases or helping us when we've maxed out our soft tissue releases. And I think that's where technology and specifically patient-specific instrumentation come into play. Obviously, all of you know this. When you have a varus knee, you want to be releasing the tightness on the medial side of the knee, and on a valgus knee, the tightness on the lateral side of the knee. As I said, all of you knew all of this already, but why is it important? In general, if you use standard methodology, standard mechanical alignment, standard instrumentation, and standard soft tissue releases, you'll be able to plan and execute about 80 or 90% of primary total knees without too much problem. But what do you do about those other 10 or 20%? of knees. And again, this gets back to the point. The goal here is to balance the forces across the joint. And I think we can explore how technology and specifically patient-specific instrumentation can help us. So we talked about some of these outlier cases. Here's a severe varus deformity, and then next to it a severe valgus deformity. In cases like this, you can say, listen, on that varus knee, I'll just release the MCL and put in a constrained implant and let that person be, and they'll probably do okay. But for a host of reasons, it would be nice to use primary implants when appropriate. And I think that if we consider technology and the idea of balancing forces across the knee as our guiding principle, that really can help us achieve that. Why are these cases outliers? In severe varus deformities, as you know, if you make standard mechanical access cuts and complete all the releases, you're still sometimes more tight medially than you are laterally. And the question becomes, now what do? Do you pie crust the MCL, which again, I think is just a different way of saying partially cut the MCL? How else do you balance this knee when you've maximized your superficial and deep MCL release, but you're still more tight medially than laterally? What are your options? I think oftentimes we just take a little bit more tibia, put in the plastic and say, yeah, this is balanced. But really what's happening is that it's so tight medially that you're not even allowing it to gap laterally. And in reality, once that patient is functional and up and moving, they're very tight medially, but still gapping open laterally because you've done all you can. Other things to think about in these kinds of cases is that the medial bone is actually very sclerotic. And if you are just trying to cut it perpendicular, you will probably end up actually cutting it in a little bit of valgus because that saw blade is going to bounce off, as I mentioned here. That sclerotic bone is also a very poor host for cementation. If you're doing cemented knees, sclerotic bone is not the best interface for cement to interdigitate. So when this happens, as I mentioned earlier, we can cram or overstuff medially. So thinking about ways that we can adjust our cuts very precisely may be worthwhile. In valgus deformities, you have a little bit more flexibility because you have more posterior lateral structures that you can release as opposed to on the medial side where you just have the MCL. But again, even after you do all of the releases in some very tight lateral and some very tight valgus knees, you may still be tighter laterally than you are medially. And as I said, the same considerations with sclerotic bone and saw blade kickoff present on these valgus knees. So at the end of the day, our goal is not to have necessarily an x-ray that looks good, but the forces being imbalanced. We want rectangular balanced gaps in extension and inflection. And sometimes that means that the rectangle is tilted symmetrically one way or the other in order to accommodate those excessive forces. So how do we get there in the outliers? One of the things that I like to think about is adjusting my distal femoral cut. I don't always just cut it at 5 or just cut it at 6. If I'm doing a valgus knee, I might make that cut 6 or 7, more valgus to open up that lateral space and extension. And on a varus knee, I might do the opposite. I might make that cut 4, so less valgus or more varus in order to open up that space medially and extension off of the distal femur. So I adjust that. I also adjust my tibial cut. I don't have an issue putting in a degree or a degree and a half of varus or valgus into that cut on a routine basis. Again, when you're doing this in a really severe deformity and sclerotic bone, often that degree or degree and a half actually is not even that much. Because of the saw blade kickoff, you're getting less than you think. And when you try to stay neutral, you'll actually under resect. I do not advocate for extreme variation. I do advocate for what we've started to call constrained kinematic cuts. But again, the goal here is to balance forces. It doesn't help you to have a perpendicular cut to the tibia in a severe varus knee where it's still too tight medially. And you can't release more because if you do, you'll cut the MCL. And it would be nice not to do that and have to use a constrained implant. So when we talk about adjusting things by a degree or a degree and a half, that's very hard to do using just our eyes or our hands in standard instrumentation. I think technology can be very helpful here. The interesting thing is that technology also forces you to plan. So even when you're doing those 80% of knees that are, quote, easier, using technology helps us plan those better and probably helps us be better surgeons. If we can make little adjustments in our bone cuts and limit the soft tissue releases, we're going to have faster recovery, less invasive surgery, and get people out more and more. I run our outpatient program here, and I routinely send 40 or 50% of my primary knee replacement patients home. Even up into their 70s. I think the oldest one that I have so far that went home the same day was 78. And there's a lot of things that go into that, but I think using this to limit your soft tissue releases, decreases pain and inflammation, that can be helpful on this. So as I said, this can help your performance even on standard knees. So let's get to the meat of it. This is the the severe varus knee that I showed you. This is the plan that I use. I use Visionaire from Smith & Nephew. And as I mentioned, I do speak for Smith & Nephew on occasion, but this is just the technology that I choose to use and the implants that I choose to use. And as you can see here, this gives me my preoperative deformity. I can see that the patient has 16 degrees of varus preoperatively. I've fixed my distal cut to be 4 degrees. So I've limited my valgus on the distal femoral cut. And you can see that on the proximal tibia, I've added 2 degrees of varus into the mechanical axis. And this plan really lays it out nicely for me and allows me to think through it, think about where the implants are going to come and sit prior to surgery. So patient-specific instrumentation really helps me think through the plan, use technology to dial in small changes in distal femoral cut angle and proximal tibia cut angle in order to really optimize my outcome. And here's what the x-ray looks like. Again, when you look at this, it does not look like it's an extreme amount of varus. I think that maybe we have a half to a degree that's in there, which you can't really see on the x-ray necessarily. And again, the sclerotic bone has probably limited as much of that as we think. And this is a nice stable CR implant without any compromise. This gentleman's very happy with his knees. We've restored his overall alignment. And again, we've restored the balance across his knee. The forces are equal across the medial and lateral side of the knee. Using that same example on a valgus knee, you can see that this person has an 18.6 degree valgus deformity preoperatively. I've adjusted my distal femoral cut to 6 degrees. So I'm adding more valgus into that cut, opening up the space laterally. And then I've added 2 degrees of valgus into the proximal tibial cut. So there's our pre-op x-ray. There we are post-op. I apologize. It looks like some of that got cut off. But again, this is not an extreme difference or an extreme change. It allows us to use primary implants comfortably without compromise. So again, in order to achieve such fine adjustments, we need technology. And the technology that's worked really well in my hands with this is patient-specific instrumentation. And full disclosure, I do use robotics as well. This talk is about 3D printing, or this session is about 3D printing. So obviously these PSI molds are 3D printed, which we'll talk about here shortly. But I think you need to utilize technology in order to make these fine adjustments if you keep these guiding principles in mind. From the standpoint of Visionaire specifically, and I've borrowed these slides from Smith Nephew, it helps me in other ways as well. In addition to balancing the knee, there's studies that have shown that it makes us more efficient, shorter operating room time, shorter tourniquet time. These have ramifications both for patient outcome and satisfaction, as well as overall cost, which are a few very relevant factors. As you can see here in the United States, we use bundled payments where we're given a set amount for the entire episode of care. And when we use Visionaire specifically, we're able to lower our overall costs. So that's very beneficial for us here. And the way that we can do that is via efficiency, lower readmissions potentially, and certainly fewer trays that need to be used. When you plan out the knee, not only do you get those angles, you get the sizes of the implants ahead of time, and it allows you to open up trays that basically have the implant you know you're going to use and one up and one below just in case. But I can tell you that just in case is very rarely used. I've never had to go more than one up or one below on either the femoral or tibial side in any of these patient-specific knees using Visionaire. This is an interesting study that was done in Minnesota where they were able to demonstrate significant cost savings in terms of using patient-specific instrumentation. I realize this is specific for Visionaire, which is the system that I use in the data that I have, but many of these parallels can be extended to patient-specific instrumentation in general. So we know that in general, patient-specific instrumentation can give us improved accuracy, improved efficiency, potentially better satisfaction, and lower cost. And all of those things are really, really important. But at the end of the day, so what and who cares? Why are we doing this? I think this is a nice clinical example. Now, this gentleman has, as you can see, has a severe valgus deformity. It looks like the video, maybe it'll play here. Let me see if I can get it to play. There it is. You can see his deformity. Now, he had a completely, basically incompetent MCL, so I knew I was going to have to use a constrained implant, but I was hoping I could use patient-specific instrumentation to help my planning here. And here's that same plan. You can see that I've added valgus into both the femur and into the tibia. And here's how it works intraoperatively. You can see those guides just sitting very nicely on both the femur and the tibia. And you can see that when I resect that tibia, I was able to plan it where I'm just skimming that posterior lateral defect. So I don't have to guess where that's going to be. If I'm doing standard instrumentation, I'm going to try to hit it right there, but I may or may not be right. I might have to recut a few times if I'm being careful just to barely hit it. But with PSI, I'm able to plan it and hit that posterior lateral corner right as it's sort of at its lowest point, which is nice. You can see that our cut surfaces are very clean. There's not a lot of sclerotic bone there. And you can see that with a laminar spreader in place with limited soft tissue release. We have that balanced out in a very perfect rectangle. There it is with an alignment rod in place. And there's our post-operative x-ray. I used primary implants. I did use a constrained polyethylene here because his MCL was so incredibly lax from the deformity, and it was just pretty straightforward. So, thank you for the time. I hope I haven't gone over too much. Patient-specific instrumentation, which is obviously 3D printed technology, has made a dramatic impact in my practice. It's helped me with efficiency, alignment, outcomes, and patient satisfaction, and it's been a great help for me. So I thank you for your time. I hope I'm able to join you live for questions later. I will stop the share and stop the recording now. Thank you, and nice to meet all of you virtually.
Thank you, Ravi. I think it was an excellent explanation. Dr. Kasha, are you ready with your talk? So we'll have a last talk, and then after we'll have 10 minutes of discussion. Srinivas, please share your screen in the meantime. We'll have a 10 minutes of discussion after all the talks. And then after we'll go on to the case discussions.
Is it visible, sir?
Yes, it is visible, please. And you're audible. Srinivas, kindly keep it to 10 minutes. Huh?
Sure. So my topic is use of 3D printing in post-acetabular fracture THA. So here is a 28-year-old male met with a road traffic accident, and these kind of injuries are very common, and displaced acetabular fractures constitute surgical challenge for orthopedic surgeons. And the same thing can be managed with an internal fixation, and this is the patient's outcome after 4 years. This is just to mention about anatomical congruence restoration between the femoral head and acetabulum is essential for good long-term results, and that is achievable. But these fractures, when they are neglected or untreated, that's going to be a big challenge. And let me take you through a case example. Here is a 60-year-old male met with an accident 10 months prior to this particular X-ray. And initially he was treated with skin traction, and he was bedridden for 3 months. So this is presenting X-ray to me. And if you can see, iliopectineal, ilioischial, both lines are gone. And of course, there is an arthritis which is established. The challenge is your columns and the posterior wall in the obliquus. So that's how a CT scan looks. Your anterior column, although there is some callus on it, but it still is ununited, and posterior wall fracture. It's basically a transverse fracture with a posterior wall component. And now you have a challenge that you have got a secondary arthrosis. So these are same kind of pictures. So in these kind of situation, 3D printing is definitely going to help. And my previous speakers have nicely spoke about how it is done and the basics of 3D printing. And so if you see this particular 3D printed model, you can actually deal with it even before the surgery itself, during your planning. And you can even know the size of your cup and how you are going to reconstruct, the steps involved in reconstruction. Here in this case, I have just used the blue color slime is actually representing the bone graft which I am going to put. and that is posterior column fixation, followed by reaming, which I have done in my outpatient room, and then I could assess the size. And this particular 3D printed model is going to help in preoperative planning of all the complex acetabular fractures. So here in this case, I have used the same steps intraoperatively. This was a transverse fracture. You can make out the transverse fracture line, and the posterior wall is gone, which was reconstructed with a femoral head graft, followed by plate fixation. And at the same time, so anteriorly, I have distracted it and grafted it to use a multi-hole uncemented cup, and got the column fixation as well anteriorly. So the basically posterior column fixation, anteriorly distracted and bone grafted, and multi-hole cup was used. The same patient, this patient was actually post-operative 6 months, very obese patient. Now you can see the anterior column is nicely healing in your iliac oblique, obturator oblique views, and the patient started to walk. The posterior column also can be seen in the iliac oblique view, which is reconstructed well. So 3D printing technology in orthopedics has been used since 1990s, and various initially used by Vigord et al. For complex osteotomy. But when it comes to acetabular fracture, when it is grossly displaced acetabular fracture, that too non-operatively treated, has got chances of developing osteoarthrosis, and residual anatomy is disturbed. Residual anatomy, which is associated with non-union, is much more challenging. So I'm taking you through another case example here. In this particular case, it was a 44-year-old male initially treated elsewhere. So this is the first preoperative picture where it was handled elsewhere, and immediate post-operative. They have done a second fixation, which has actually landed up with this particular picture. And in this particular situation, patient presented after 9 months from the first post-operative picture, that is from the index surgery. So the challenge here is assessing the integrity of the columns and removal of the hardware and whether it is infected. So here in this case, although the inflammatory markers were okay, intraoperatively initially planned for the hardware removal, where I could actually have sent frozen section, which is obvious of infection, and which I have handled, of course. My initial plan was through 3D printing, and the plan was to remove the hardware and then simultaneously do a total hip arthroplasty. But this was the initial picture. You can see the posterior side, you can only see the plates, but there is no bone or posterior acetabular wall left on the posterior side. So the same pictures, and I have got a preoperative CT to correlate. So now the challenges are anterior plates, and you have got 3 plates posteriorly, so which are to be addressed. I'm sure, I don't know where it is. Yeah. So this was the first post-operative picture where I have removed the posterior hardware, and then antibiotic cement spacer was put, and the plate is retained on the posterior wall side, and cement to contain the cement also. And after 6 weeks, once infection is settled and covered with antibiotic, he was used with a MRS Titan uncemented cage system, wherein we have reconstructed the acetabulum and then put a MRS Titan. And this is the post-operative picture. In this particular thing, the anterior plate was retained for the reason of it is not coming in the way of fixation, because it's been approached from posteriorly and there is no interference of the plate into the acetabulum. And here we have used the kickstand screw to get an inferior stability. And that is post-operative picture after 3 years. So your column restoration, and if you can see, posterior column is also nicely healed in your iliac oblique view. So the take home is primary internal fixation is ideal in case of complex acetabular fractures, and best outcomes are there with primary restoration. Even if it lands up in arthritis, it will leave good columns where total hip replacement with simple cup is adequate. Whereas 3D printing always helps in assessing and planning in complex acetabular reconstructions. And femoral head can be used as a posterior wall reconstruction. THA has been used as primary and delayed solution for fractures or sequel treatment. When talking about delayed treatment, total hip arthroplasty revision concepts guide the surgical decision because of the loss of bone associated with column non-unions. Thank you.
Thank you, Srinivas. Now we'll have the discussion on the presented talk. Do we have Dr. Ravi Bashal with us?
Sir, shall I close this?
Yeah, please. Thank you so much. Vaibhav, do we have Dr. Ravi Bashal?
No, I don't think he's been able to join so far.
All right, it's okay. So we just you'll have to pitch it now for him also. So
Sure.
There are some questions in the chat box, and to begin with, to all of you experts, I think the most orthopedic surgeons, arthroplasty surgeons would like to ask that: do you reserve your 3D printing for only complex cases, or some of the less complex primary also do you suggest?
That's for me, is it?
Yeah. Any one of you can
Yeah.
pick it up.
Basically, as I said, 3D printing, you don't need it for every case. That's true. You need it for places where you need to understand what the anatomy is. However, if you choose to use it, there's no harm. It could be a good doctor-doctor communication tool. It could be a doctor-patient communication tool. But you really don't need to. It's like navigation. Do you need to open up your navigation when you are driving home? You know all the
So
ways.
we had a start with the conventional arthroplasty, then after the navigation, and then PSI, which is of course a 3D printed instrumentation, robotic. So the question of all the beginners in any technology will be, why should he use it? So I think the message is clear from your side. Krishna, would you like to say something on this?
Absolutely, sir. It is for patients where we anticipate some sort of a bone loss. And currently, I don't think, rather than preoperative planning, it is more, we are more excited about the 3D printed implants, maybe patient-specific implants, the 4 verticals Vaibhav were talking about. 3D printing as a tool to plan is a very basic tool, and anybody can use it in difficult situations. But we would keep everything ready any which way. So we would not just take a 54 cup if we templated on the model. and an augment of the same size, we would not go only with those two, right? So it doesn't really add that much value for really experienced surgeons. But the real value is in getting 3D printed implants, I would say. But
we can safely say, that this is the one of the step towards the patient-specific implants.
Yes, that is right. And in a complex scenario like a revision where you have a 3D modeled augment and everything placed, and it's very exciting that Indian companies are coming up with that, with trabecular metal and all that. So it will save a lot of time intraoperatively trying to, fiddle around with the augment, the cup, and then trying to get the best possible bone.
And you'll be more sure before you actually get into the surgery.
Absolutely. Sure.
Right. So one question for Dr. Ashish was there on the chat box. What radiological investigations are required to make a 3D model? Only X-rays enough, or CT scan, or MRI, or all of them? Ashish, would you like to take it up? Yeah. Is it there?
Sure, the Ashish is there. So basically, you need DICOM images. So primarily, you need CT scan. Anywhere we have got axial section. Of course, now the MRI-based printing is also possible. And there are certain software which can extrapolate CT images based on the normative data. But for most of us, it is the CT-based thing. So 95% of job is done on CT. Sometimes you can use MRI, and very rarely certain advanced software can extrapolate X-rays.
All right. Thank you.
When there is metal there, when there is metal there, like a hemiarthroplasty or even the plates that Dr. Kasha showed, does the scatter really come in the way of your precise planning?
So interesting, because the segmentation is the tool that is used. And the reason why CT is used is because it can work on Hounsfield unit. You can eliminate any Hounsfield unit and choose a particular Hounsfield unit. So if you want, you can say that I want only a particular Hounsfield unit. So the highest Hounsfield unit is of metal. You can eliminate that spectrum. You can eliminate soft tissue. So you can only choose a certain spectrum and it will print that particular Hounsfield unit. That's the advantage. And that's the process called as segmentation. You segment the area that you want to do it. So you can eliminate anything that you want. You can only print vessels, you can only print metal, you can only print soft tissue, you can only print bone. Bone is the easiest because that spectrum is unique.
All right. So Dr. Rajput had asked rightly that which company provides what? So any specific, would you like to mention about any company which is providing? See, our viewers, if they want to have a 3D printed implant, what do they do? What is your suggestion for them?
So there are a lot of companies that are doing it. There are two ways of doing it. You can yourself approach any 3D printing metal thing which does engineering work, but it takes a lot of time because they do not understand this stuff. So what I do typically is to tell them that I want a debut cup, so that my liner fits into that 3D printed model. So the company that understand that I work with is Incredible 3D, which is a Pune-based company, because they have it. But virtually, it can be any metallurgical institute where they do it. Most IITs have it. Many of the bigger car manufacturing companies outsource their business to a lot of these 3D printing bureaus. But few of them work specifically for orthopedics and dental industry. So it's easier to work with them. So Incredible 3D is one of the established one.
Right. Lalit, do you have any suggestions on this?
Regarding the first part, I think we can also use 3D printing very effectively in education. A typical example would be if you want to do a hands-on workshop for revision THR or TKR, you can never get cadavers and you cannot create those. But if you have the same case which you have already managed, you have the CT scan, you can print multiple models and multiple people can plan out and practice and discuss on the models. And regarding printing, yes, it depends whether you are printing plastic or metal. Plastic is now available all cities everywhere around. You can outsource it, and you can also have your own printer, not very difficult to handle. And metal printing still not very commonly used. It will be used in very, very niche areas, and you would like to go through.
Yeah. And lastly, what is the rough cost of this 3D printed implant and 3D printing itself?
The 3D printer is
It
will be
could
anywhere
be
between 50 to 50K to 10 lakhs you will get, but the common one is the FD modeling, the fuse deposition. It's called Flash Forge. So roughly a good one costs around 2 to 3 lakh rupees, and institutions can purchase it and keep it and use it for their own work.
So can I give some answers, because I'm coming from India, where we already have procured a metal printer. It's a medical device company for last 25 years. And this company is Orthotech India Private Limited. Since last 3 years, we are working on this. It's highly required that the manufacturing of any implant which is class 3, class 4, which is going to go in the human body, usually has to go through certain compliances, even if it is a PSI, right? So getting certain institutes like IIT or certain engineering institutes to print an implant usually doesn't get into the ethical standards. And hence we have now went into the medical device company, who, like any other medical device company abroad. So if you see Smith & Nephew, if you see Stryker, all of them at their facilities have got metal 3D printers. These are they have around 6 to 7 metal 3D printers. They are coming up with 3D printed acetabular cups, femoral stems. They have now come up, Depew has come up with an uncemented Attune system, which is again a trabecular system for a tibial plate as well as for a femoral component. In India, Orthotech as a medical device company is the first company. We have already procured a metal printer with a turnover time of not more than 120 hours. Rightly said, we're creating an ecosystem where me being as an orthopedic surgeon would be the front line of contact, and all those files, DICOM files, which would be coming and then interacting with the orthopedic surgeons, interacting with the designers to design a prototype and then to come up with a final implant, metal implant, would be now much possible. The prime focus now for this company, which is predominantly an arthroplasty company, it has an entire range for hip arthroplasty, shoulder and knee arthroplasty. I'm not promoting the company, I'm just promoting the technology, is that we are now trying to come up with solutions, as I was rightly saying, for creating those metal, if there's a big bone defect, if there is a need for a acetabular component to be created along with a bone defect, you don't need augments. You can directly print, doing all those studies, a complete one piece, which would be allowing you to cover the defect in a trabecular pattern. This trabecular, metal trabecular, which will be titanium, would be enabling the bone ingrowth from any part, the bone that is going to, apart from that, it will stabilize, give you a complete anatomical reconstruction. Same for tibia. Same from
one question here, one question logically will be, when you introduce an implant in country like India, every implant goes through a huge process of clearance from the government. So how are you able to provide the 3D printed implant in a specific period of time?
Yes. So this is a patient-specific implant. This is a patient-specific implant. The government has enabled the surgeon to get a patient-specific implant, but it has to be a medical device company with all compliances. So that means the process of additive manufacturing is nothing, but it's a change in the way the manufacturing is happening. So it's a CNC is one part of manufacturing, and additive layering is another part of. So a medical device company has just changed. It's not changed the implant per se. It has innovated that implant into a patient-specific implant, which is through a medical device company approved by the government through all the compliances. That's exactly the reason why for IITs or for companies like mechanical companies to print, now they are doing it, but later they will have compliance issues.
So what we understand is the clear message is that it is possible in a specific period of time. Now,
Yes.
now we'll go on to the case discussion, and the first case discussion will be by Krishna.
Thank you,
Yes.
sir.
Thank you, Krishna.
Yeah, so we actually did quite a bit of 3D printing with Dr. M.V. Reddy, who works in Sunshine Hospital.
Who's this?
And as was pointed out, the accuracy of two-dimensional images, like this one, the questions are which is nearer, the antelope or the elephant, and what is a man doing? And a lot of the results indicated that both children and adults found it very difficult to perceive depth in pictures. So this led to the concept of this 3D planning. And the question was asked, we need DICOM images, preferably about 1 millimeter thickness on a CT to get this thing. So quickly we move on to the case. So this is the first case. The 22-year-old girl with sickle cell anemia. You can notice this sort of bone infarct here. She was operated for a total hip arthroplasty around 4 years back and developed progressive pain with normal ESR and CRP. And this obviously had an intrapelvic protrusion of the cup, which required CT angiography and planning on the sagittal use. And it showed that the vessel was very close to the cup. But for the reconstructive purposes, we did get a 3D printed model, and we saw the extent of the defect, whether the columns were intact or not, what was the size of the socket, and where was the host bone for fixation. And this patient, we actually did a double approach. So the ilioinguinal approach, you can see the external iliac vein there, and then the cup very close to the external iliac, and we retrieved it from intrapelvic, closed it, went from the back, closed down the defect, impaction bone grafted it, and then put in a trabecular metal revision shell in a little bit of retroverted position to accommodate the exact bone defect, and then used a cemented liner in the correct anteversion and inclination. And this is the immediate post-op, and this is around 8 years follow-up of the same patient showing good incorporation. So this was a case where we use the 3D printing technology.
So can you show us, Krishna, here the CT scan that you took for the 3D printing?
I don't have the CT scan here, but it is just a standard CT with 1 millimeter DICOM images. So it's just sent as a CD file. Any standard CT scan, you can send it to the guy. And this was actually printed in-house in the hospital itself. We printed it out because we have the Flash Forge Dreamer with us, and Dr. M.V. Reddy is an expert at printing it out. So he just took a couple of days, got the model done, and that is what he does all the time. So whenever we have a complex case, we just do a CT, send it, and get it done.
So this was a very difficult case. You controlled the artery from inside, from the separate incision.
That's right. So because I don't have the sagittal CT images or CT angiography, and the angiography images showed that the external iliac neurovascular, the vessels were in close proximity to the cup, and if it is about a centimeter or less, then we tend to go intrapelvic to retrieve it. Of course, now you have other strategies like trying to put in a Fogarty catheter in a minimally invasive manner, and then the AIMS group have published that technique. But we have done quite a few of these cases where we've done either a full ilioinguinal approach, or sometimes we've gotten away with just a modified Stopass approach based on the individual situation.
So you took out this cup from the pelvis, from the pelvic
incision. Took it out from the front and closed it down, and then did the definitive surgery from the back. So you can see we put in a mesh inside to contain the defect, put in allograft from the bone bank, and then used a rim fitting TM cup, which we had already planned on the thing. So you can see it's a little bit vertical and retroverted. And you can use a cemented liner inside, which will lock the whole construct down. And you can adjust the cup inclination and version through the cemented liner there. And this was done around 2015, if I'm not wrong. And this is the latest X-ray showing good incorporation and a stable construct.
Yes, excellent result. Yeah. Any questions? Yeah, Krishna, maybe you go on to the next one.
Yeah, so I'll just present one more case and then we can move on because I have 4 cases,
Yeah.
but I don't think this is just to
Yeah.
illustrate how the 3D printing can be useful. This is the case of a Crow 4 dysplasia, and initially 2014-15 when we started using it, we were trying to do it in all the complex cases. It was acetabular fractures, dysplasia, and just for teaching purposes as well. So this we have these CT images, what we sent it, and you can see how the pelvic model comes up with the printed bone, and you can do a mock surgery preoperatively. This is how the femoral head looked when we took it out, and this is an intraop picture showing how the heads match. And we have actually published the accuracy of the 3D printed models on taken cadaveric bones, 3D print, took CT scans of that, did a 3D printing of that, and found that it was about sub-millimeter accurate, including all the shape, size, everything. And you can plan your surgery where you are wanting to put in your sleeve, what is the size of the sleeve, where you would plan the osteotomy, what is the size of the cup, everything you can plan pre-op. So it's interesting to teach the residents as well as the DNB students to take them through the surgical steps, and you replicate the same thing intraoperatively. And this was what was done for the patient.
So this was the subtrochanteric osteotomy you did.
That is right.
You assessed it preoperatively.
Correct. So the for dysplasia, we found it useful to determine the socket size. Sometimes the socket size is, we've used 38 socket size, 40, 42, which are not routinely available. And they come with a 22 millimeter head and a single head size, neutral liner and all that. So you can predetermine your size, keep everything ready, and then go for the surgery. That's what you can do.
Thank you so much, Krishna. I think it's a wonderful case. The next one, Kalaivanan, would you like to share your screen and your first case?
Are you able to see, sir?
Yeah.
Yes,
Yeah.
please.
Yeah.
Yes.
So greetings from Chennai, sir. Thanks for the opportunity. So actually, we also started using in 2015, especially for the complex post-acetabular fracture cases. And this gentleman was 34 male, and he was attempted acetabular fracture in 14, but failed because of bleeding. And 15, he came with central dislocation. And the investigation we did ESR-CRP to rule out infection, and we did the X-rays and the CT scan. And the CT scan, the priority is to have CT scan at least a 0.62 mm slice thickness. And we have in-house Dr. Shantanu, who is well aware of. So once the CT images, the DICOM images are converted into a 3D modeling software using the Mimix, and then slicing software, Cura and Cretabar were used. And once it is given to the 3D printer, we have a Cretabar. This is our in-house 3D printer. And the material what we use is PLA. And roughly for a full pelvis, it cost around 15K in 2015. And right now you are able to do the same thing in 10,000. And once you get the model, you have a tactile sensation, and you can really have a feel of acetabular reaming. So preoperatively, we have what is going to be the cup size, and especially the such big, huge cups when you are planning for a jumbo cup or an augment, you have to order pre-order. So we were able to determine the size as well as the augment size and as well as the trajectory, screw trajectory side. And so we had a lot of confidence when we went into the thing. We are able to put the cup of the same what we have targeted 66, and instead of augment, we were able to get the same stability with the help of an femoral graft to cut down the cost. And the post-op X-ray was like good, and the patient has been doing good for the last 8 years. And this is another one case where we did a 3D printer, and for this case we used an augment as planned and also the same number of screws. The third case, when this such a complex case came, we had a plastic surgery, but once you have the prototype, it gives a lot of confidence so that intraoperative tension is less, and immediately we are able to replicate the same kind of cup size and as well as the stem what we have been using. And this is one of our latest where this patient came with a failed broken plate and an old case of blastoma. And for this, the people suggested a total femur, but we were able to get the 3D printed implant this time. And the patient has been doing good, and we are waiting for the long-term results. And this is another one case where we are, for a fused hip, we are able to get the 3D printer model, and you are able to color decode which part to be removed first and rest, so that the intraoperative Zigo is also available, so that the reaming can be planned. And we also use in case of complex spine as well as trauma surgeries. Thank you, sir.
So what you showed is that not just the arthroplasty, but even the spine surgery and trauma surgery, it can be used.
Yes, sir.
Right.
Dr.
Can you
Kalai?
go to the last but one? Yeah.
Yes,
No,
sir.
just one question
Dr.
to
Ajit,
Dr.
yeah,
Kalai.
please.
No.
Yes, sir.
These implants are sourced from where? The regular suppliers or Indian companies?
So this is one of our Indian company, like my segmented, they have Mr. Jalal, and but the sterilization and the final finishing was done in Israel. But they told in coming years it will be available in India also.
Okay, thank you.
Yeah, that's a very nice solution. Yeah. Any question for Dr. Kalaivanan? Rakesh?
Just one question, may I ask?
Yeah, please, Ajit. Yeah.
We are talking so much nowadays about spinopelvic alignment.
Yes, sir.
With this sort of technology, can you address that, or is that your surgical skill that comes into play there?
So the spinopelvic, most of the time it is like dynamic, and when the spinopelvic preoperatively they are like more fused, and once we get down and do the surgery, it becomes like open out, and that I don't know, like 3D model will be really useful or not, I don't know.
I think what the 3D model will give is just the anatomical assessment.
Anatomical, yeah.
Not the dynamic assessment.
Can I give an input there, Dr. Rajiv?
Yeah, please, Lalit.
So the input for a 3D printing is the DICOM images from CT scan. So now actually you have softwares where you can virtually plan out your spinal pelvic alignments and actually also see what happens if you do a correction and what will happen if you do a cup placement in a particular position. So you're not actually printing the whole model, but then you use the same DICOM images to do a virtual simulation of the whole thing.
Okay, that's very nice. Thank you, Lalit. And now I think the Professor Sean Young from South Korea, he'll be showing us his case, and I think Shobhit, you will be supporting him.
I'm going to talk on behalf of Professor Sean. So
yeah, please do.
Just start my screen sharing.
Yeah. Thank you, Professor Sean, to join us. It's a wonderful gesture.
Yeah, full screen.
Just go to the slideshow, please.
Yes, 1 minute.
A little to the left there. To your left.
1 minute.
The stand there.
Shobhit, just go to the slideshow and then start.
At the bottom of your screen, where it says 70%, no? Come to the left there.
So there is already one. Yes.
Just a little to the left, there is a slideshow image icon.
Or you can go to the slideshow on the top line where you can read the slideshow, right? Yes. Just click on this and play. No, don't set up. Start from the current slide. On the left side, that's right.
Yes. So a very good evening to everyone. So the slide, I'm going to present 3 cases. So the introduction is the challenges which we face in revision hip arthroplasty cases, that is soft tissue scarring. We have to deal with severe bone loss, disturbed bone biology, disturb anatomical landmarks, and difficulty interop. So what are the options for acetabulum with impaction bone grafting, structural bone graft, reconstruction using cup cage combination, trabecular metal augments, or recently custom-made acetabulum implants? So I'm going to present 3 cases. So first one is, he is a 74-year-old male. He was operated with primary total hip replacement 18 years ago. And last year in September, he had a fall. That was a trivial fall. But he came to us last year, September, and this was his exercise that at that time with loosening of acetabular cup and proximal femur and acetabular, periacetabular osteolysis. So this was the CT scan which we did on after patient visited to us for the first time, which showed severe bone loss of posterior column, superior roof of acetabulum. And then we probably felt, because of proximal femur osteolysis, we felt some kind of benign lesion or probably infection. So we removed the acetabular socket, we put cement spacer, and there was trochanteric fracture as well. So we dealt with it by doing tension band wiring. So subsequently, we got 3D images using CT scan of the patient, and we have even made custom-made acetabular socket of using the 3D model. So we could see it was a tri-flange acetabular socket which had good coverage. And then subsequently in December, we operated him with the custom-made implant and cemented cup inside that. So second case, she was a female, 55 years old, with around 2.6 centimeter proximal migration of femoral head and arthritis. She was operated elsewhere in 2017 with primary total hip arthroplasty, but within 6 months, the acetabulum socket was loosened and it was moved from its place, inferior migration. And since the patient continued to walk on that loosened implant, after 2 years when she came to us, this was the picture with severe osteolysis with acetabular socket completely loosened and fallen in the inferior aspect. And this was the CT scan. So, as you can see, there is severe bone loss with probably pelvic discontinuity as well, with no medial wall absolutely. And then this was the 2D CT scan images. And then she on CT scan, we find some suspected lytic lesion, but we are not sure about what kind of lesion is this. So again, we did her CRP, SR, everything was within normal limits, but still we didn't want to take any chance. So we did the acetabular socket removal and then cement spacer. And after 1 month, we did 3D modeler and then customized the implant for her. And then we assessed preoperatively before taking her to the OT. We could assess the screw length, direction, and how is the fitting of the custom implants with the patient-specific 3D model. So this was the picture immediately post-surgery. We could see the implant fitting well. We retained the femoral stem, and again trochanteric tension band wiring was done because it had again fractured. So we could use Zimmer 44 cup inside the cemented cup inside the customized acetabular socket, and then we changed the head as well. This was the patient walking within 10 days after the surgery with walker support. 4-month follow-up X-rays show good integration without any signs of lysis. This was a CT scan 4 months when she came to us again. The third case was a 62-year-old female. She was operated for left total hip replacement around 20 years back, and then she had a fall, and following which she didn't visit it to us at that time, but she visited multiple doctors after that, with showing the old X-rays which showed completely dislocated joint with acetabular socket lying posteriorly, and the proximal trochanter is comminuted. So when she came to us last year in July 2022, the X-rays were nearly similar kind of thing. We did her CT scan So CT scan again showed severe bone loss in posterior column defect, and this was a CT scan. If you can see the videos. Next, we did our 3D model CT scan also, so where we can see the actual defect. So we did CT angio to see the location of the vessels. So as you can see on the right side, it was the superior gluteal vessels were very close to the dislocated implant. So we took care of that during preparing the customized implant as well. Her lab values as per the infection, ESR, CRP, WBC count were within normal limits. And then this was the post-op X-rays. This we had operated recently, so I don't have her any follow-up X-rays as such. But currently she is day 7 post-op, but X-rays look probably a good fitted acetabular socket and good alignment as well. The implant alignment and inclination was predefined on the 3D on the CT scan images, and the implants were made as per the alignment and inclination which was pre-decided by the Professor Sean. So advantages are
right, Shobhit. Yeah.
Yes. So
because of the shortage of time, would you conclude?
Yeah, I finished. So the advantages are triaflex component, improved stability and fixation, more anatomical reconstruction of center of rotation, and increased implant bone integration. High risk for complications such as prosthetic joint infection, since it required extended approach, the surgical time was increased, and so probably it could have more chance of infection. So these are some studies which shows nearly 90 to 95% success rate with customized acetabular implants, and then probably that's in. Sir. Thank you.
Thank you, Shobhit. Is Professor Sean available here for discussion?
Probably not, sir.
Is he online? No. Okay.
No.
So, any questions to Shobhit on this, on the cases shown?
I'll ask you a question, Shobhit. This is exactly what we are planning to do in India. Who's doing the designing of this tri-flanged acetabular components?
Sir, this is an Korean company, which is Korean Tech. So it makes models as well as the implants.
Okay. Thank you so much.
Thank you so much. Now, Lalit, can we request you to present your one case and we discuss post that?
Thanks a lot, Dr. Rajiv. I'll keep it short and sweet. And
Lalit, your screen is not visible.
Yeah, it's just coming in.
Okay.
So we've actually probably understood that absolute indication of 3D printing is probably the acetabular defects, and treated or a neglected acetabular fracture is a very, very fair indication to apply this technology. So we've already seen cases regarding these applications, so I will not go into them. I'll just skip those cases, and I'll show you two applications which have not been talked about. So again, this is an acetabular fracture, and being a T-type fracture, the transverse acetabular ligament is also gone. So the most friendly reference for the THA surgeons is gone. So we can actually design a jig to get the most anatomical positioning of the center of the hip using the opposite side, which if normal is used as a reference. So you can see the two rings. So on the disease side, the ring is supposed to be over here. Am I audible, Dr. Rajiv?
Yes. Yes, sir.
Yeah, you're audible. Yeah.
So these are the type of jigs we create for acetabular cup placement where the anatomy is distorted, and these can be used in neglected cases. It can be used in post-infective sequelae. It can be used in bony ankylosis to guide your osteotomies as well as placement of your cup. And a second interesting application would be when you're dealing with a two-stage revision and you want to make a cement spacer, and you're getting a CT scan of the patient's limb. So you can easily do a reverse engineering and create a customized sort of a mold in which you can pour your normal antibiotic cement and create the most cheapest possible customized solution for a two-stage division. So you can use it both in hip and knee, and the requirement is the CT scan of the patient. So these are the two applications which I wanted to share. Thank you so much for this opportunity.
Thank you, Lalit. I think it's very, very well explained. So what we understand is that about this interesting technology is a lot of inputs from the surgeon, and it is helping in explanation to the patient and family, and also for as a teaching tool in teaching our younger colleagues about the difficult situations. And Lalit, what you rightly mentioned is that this is the 3D printing is most important use for this will be the difficult acetabular defects, right? Any comment from any other faculty on this before we close the session? Ajit, would you like to comment on something?
Yeah, I think it's a very useful tool. I think everybody is talking about robotics and other things, but I think in a day-to-day scenario, bread and butter for the major joint replacement surgeons is, I think, these sort of things. And I think this is a very handy tool to have. And then the future looks even brighter with the 3D implants coming into play. Probably there may be some question about quality control and other issues later, but because I think the mega players may be pushing the smaller companies, like it happens, the market dynamics, I don't know how it will work out. But I think overall, it looks, the future looks bright.
Yeah, thank you, Ajit. Because you want to comment on something. You're muted.
You're muted.
Yes, sir. Dr. Ajit raised a very right question regarding the market dynamics. So, as far as the compliances are concerned, and as far as it is for the medical device companies in India to take the lead, because for international players like DePuy, Stryker, Zimmer, they are already doing 3D printed acetabular cups and femoral stem, but for them, it is for them to import it to India. And if you're going to ask them about the pricing, it's going to be very high. Same 3D printer metal printer which we procured, which has costed us around 8 CR. So someone was asking us about the cost. The product which will come out of this would be expensive, but not as expensive as it is in the international market. The same quality. It will be the same quality because ultimately it's the printer which is going to print whatever computer aided design or an STL file that you are going to create, and post printing, finishing and processing is going to be the same as any medical device company is going to do, because it's going to be class 4 implantable implant, right? So we are very sure that the quality is not going to be a compromise anywhere as far as
right, thank you so much, Krishna. You have been using it a lot. The last question to you is that, do you think that this technology is like our viewers, our younger colleagues can take this message that it is not too difficult to have a 3D printer in your institution?
It's like I see a lot of young surgeons who are actually taking this up. So they are doing projects with IIT, doing PhD programs with 3D printing. It's very appealing to them, intuitive for them, and it doesn't take much time to, as Vaibhav has shown, Dr. M.V. Reddy, some of them are all orthopedic surgeons. And there's one colleague of mine, Dr. Sunil. So they've all taken it up. There is an in-house 3D printer. At least for the planning part of it, it is pretty, simple to, do the thing. Just take 6 to 8 hours. Then there is the issue of this resin causing some sort of a droplet type of injury to the lung, and also you need to be safe with respect to how you do it. Right. But the real excitement for me is the 3D printed personalized implants. I think that is the way hips, especially the stem and the even knees, for that matter, to some extent will go. and 3D printing is going to take over the way the implants are manufactured in the future. That's what I feel.
So you rightly say that this is the one of the relatively older technology, and will be taking a better shape in time to come.
Absolutely.
Yeah.
Dr. Rajeev, can I
Thank you
make a
so much.
comment?
Yeah, please.
I think I would say that if you have a patient who has a soft copy of a CT scan, take it and start playing with it to create STL files. And it is not a hell of a cost to get it printed. So there was a question whether you use it only in simple cases or complex. I would say if you have a soft copy of a CT scan, start using them. You will definitely get deeper into planning.
Very well, very nice words. Thank you so much, everyone. Thank you so much to the faculty and all the participants. I think it's a good technology. It is good to learn about it and good to keep it in practice, as Lalit has rightly mentioned in his last